through a conversation about medical billing, go ahead and let us know where you're from and what your favorite parts of summer has been. Summer is coming over to a close here soon, so I got to know what's going on. Um, awesome. Thanks, Dr. Ruiz. We got a lot of people on already. Shoot, I was like, oh, look, people, we started the meeting. So it is 5 o'clock Pacific Standard Time, 8 o'clock Eastern Time. And so we're going to get started in just a minute. We are going to let a couple more people get logged in here, and we'll get going. So Dr. Paz and I were just speaking about medical billing considerations and different models that practices use. So hope you enjoyed a little bit of that conversation. Oh, got some doctors on here that we've seen before. So awesome. Georgia docs. Yeah, we were just talking about Georgia and home sleep testing stuff there. It is also interesting, Dr. Paz, have you ever taught in New York or New Jersey?
No, Boston, but never New York or New Jersey. No.
Got it. Yeah, it's they have a little bit more of a challenge. You have to either know physicians or work with telemedicine solutions to start testing patients over there. So it's been a fun little challenge to navigate since I think it was the beginning of 2020 when those guidelines came public knowledge. So
Okay.
yeah, so they've got a little bit more obstacles to go through over there. So I think Dr. Walker, thanks for jumping on. Glad you're excited for tonight. Oklahoma. I have a lot of friends moved over to Oklahoma from California. So Texas, Arizona, and Oklahoma, those targets for the Californians right now. So cool. Well, let me introduce Dr. Paz, and we'll just get started with some disclaimers and really just kind of explore this idea of provisional therapy with one of the experts tonight. Dr. Paz has got a really interesting history in that his approach to getting started with sleep was probably the most unique I've heard so far. One of the interesting things that he's actually been working in specialty practices where they pretty much only do sleep for the last 2 years. He's had over 8,000 patient encounters. He's also authored courses and spoken for the AADSM and the U.S. Army, and he's on faculty for the University of Texas, San Antonio. And today he's going to share with us about provisional appliances. Now, before we jump into that, I have to give some disclaimers. The first disclaimer is that this is a PACE webinar, which means that we provide CE for the webinar at the end of the night. So at the very end of the hour here, when we get to the question and answer section, we're going to be posting the CE link inside of the chat box. It'll also be emailed to you shortly after the webinar. So if you don't have, if you're not able to get a hold of that, then just email the email that was sent to you. Respond to the email that was sent to you when you registered, and we'll get that handled. Additionally, we have to say that Awaken to Sleep is a for-profit company, and this is sponsored by Airway Management, who is just a great appliance manufacturing company here in the US and I guess internationally as well. So I'm probably forgetting a disclaimer or two. So if I think of those later, I'll come through. The last thing is, if you have questions, please enter them in the question and answer section. We already have someone who's jumped in with the question, so thank you. And if you have a chat, a comments, or something funny you'd like us to hear or see, go ahead and put that in the chat box. We are monitoring that as well. So with that, Dr. Paz, do you want to say anything as we get started here?
No, thank you for having me. It's great to be here, and I look forward to tonight's talk.
Great. Well, I think that's it for me. So Dr. Paz, take it away.
Thank you. Really is a humbling experience to be invited to speak amongst your colleagues. So thank you. A little bit of my background. I went to sort of a San Antonio fella, went to St. Mary's here in San Antonio, got a biochemistry degree, did a little bit of craniofacial training up at Tufts, finished up my clinical training at UT School of Dentistry in Houston. Prior to going to sleep, I had a pancreas restorative practice, oral facial pain, that kind of stuff. And my training has really been limited to these two colorful fellas. You may or may not know them, Richard Drake and Keith Thornton. Absolutely fantastic. Some of the best sleep dentists in the country, and I have a lot to be grateful to both of them. We got a lot of ground to cover, so let's dive right in. You know, when when you when you start getting into your dental practice and you start looking at common patterns, you realize, why not oral appliance therapy? The old notion used to be, well, let's convince the patient they have this issue, they may have this other issue. No, that's, in my opinion, that's no longer acceptable. Now it's, why isn't the dentist jumping in and doing some of this load, especially if you consider that physicians, they don't ask about sleep, right? So less than 10% of physicians ask about sleep. So who should be asking about sleep? If physicians aren't asking about sleep, then who should be? Okay. In 2019, the World Health Organization, they updated their position from 2014 to close to 1 billion apneics. Okay. So in 2017, there was a poll, and the American Dental Association determined that 1 out of 100 dentists was actually screening for sleep. So again, I'm really going to ask the question, why not oral appliance therapy? So let's see if this is an individual I don't know, you guys might be familiar with, might be you. If you guys notice, he doesn't snore very loud. I mean, I can snore, I'll tell you that. This guy does not snore very loud. And then during this period, I think he has an apneic event of about 40, 42, 43 seconds. Just consider his oxygen levels. What do you think his heart rate is doing? Okay. So it's no longer looking at his AHI, but also you want to consider, what is his sleep apnea burden index? And this is just one little epic of the entire night. Okay. So I'm sure we've all seen somebody, that individual, again, might be us. We don't know. But what we do know is we're in prime time position. Okay. So we should be screening, right? If we're following the American Dental Association. We mentioned briefly there's close to 1 billion apneics worldwide. What is really important is this sort of started in 2016 with the SAVE trial. Now, essentially what it said was that CPAP wasn't the gold standard that we thought it was. So we kind of say maybe it's sort of the gold plated standard. Okay. The Department of Defense and the VA, full disclaimer, here in San Antonio, we have a lot of military, a lot. So I follow very closely what the Department of Defense says, just because I have a lot of them in my practice and I love the military. Okay. So they put out a sleep disorder breathing guideline. Page 26, if you go to that document, I encourage everybody to download it. It explicitly states, if you're mild to moderate apneic, you should consider oral appliance therapy as initial treatment. Okay, not as alternative, but as initial. I think we're all pretty familiar with the HQR report that came out, kind of stating the same thing that the 2016 SAFE trial put out. June 21st, American Heart Association, they put out their scientific statement, sorry, not scientific paper, and they too recommended mild to moderate apneics receive oral appliance as initial therapy. Of course, the big bomb just came out a few weeks ago. Now, this is in the United States only, 3 to 4 million CPAP recalls from Philips, but we know worldwide that number is closer to 16 million. So why not oral appliance therapy? So where we currently are, as we alluded to, CPAP, the gold standard for treating obstructive sleep apnea, we know it has poor compliance. Okay, that nice Sutherland paper in 2014, it essentially said that oral appliance and CPAP can't be as effective. Why? Because of the reduced compliance with CPAP. So this is very common knowledge. I'm just briefly going through this because it is important. You have to be comfortable, in my opinion, okay, to be a dentist living in the medical world. That's just, it's a medical disorder. Depending on your model, you bill medical insurance, and this is considered a medical appliance. So that's why I like to dive into the literature. So hopefully what our outcomes are today. So we kind of look at the impact of obstructive sleep apnea on the mouth. We explore provisional appliance technology. We evaluate the best practices for combining dental and sleep treatment planning. We learn how to increase profits and patient compliance in your own dental sleep medicine program. So by definition, obstructive sleep apnea is a chronic medical sleep breathing disorder that is characterized by repeated episodes in which the tongue, and I love to say the tongue because I love this slide during my consults, soft palate and other related tissues collapse the upper airway during sleep, reducing the amount of oxygen delivered to the lungs. So we do know it's a progressive disorder, meaning as we get older, right, pharyngeal constrictor muscles, different muscles, the skeletal muscles of the body lose their patency, they lose their tone, and it kind of makes us a little more susceptible to having sleep apnea. So if we have sleep apnea, how do we know? So this is just a general layout. There's various ways of doing this. You can have a cash model. You can have a model that you want to incorporate this into your own dental practice. You can have referrals from other physicians into your dental practice. This is just a template. These are just some recommendations. So screening, I recommend that you screen your staff, for example. If you're not implementing dental sleep medicine into your practice, start by screening your staff. Okay, you can test for obstructive sleep apnea. You need a prescription for appliance therapy. You do the consult and the exam, impressions, device delivery, calibration or titration, and then the follow-up sleep study. Okay, so this is just a template. Again, nothing set in stone. Some patients will want to know, and they'll ask, well, what exactly is this doing to my airway, right? So this is another slide that I like to use during consult. On the left is sort of the neutral, comfortable position, if you will, with the oral appliance in the patient's mouth. On the right, we've advanced 2 millimeters, and what's of interest is to notice the volume, okay, that we have increased as far as the airway goes. Some patients like to know because they're in disbelief, right? This is another slide that I like to utilize. What's important is on the right. So typically Friday evenings, I like to have a little bit of wine. And sometimes I forget to use my oral appliance. And my mouth is open, and that's kind of what my airway looks like. So I do a lot of snoring, a lot of apneic events. Okay, we sort of tell our patients that it's CPR while you sleep. We're all familiar with CPR, and we know that the chin thrust is one of the most important things that we're able to do. But why? Because we open up the airway. Okay, when we have the oral appliance in an advance of 2 millimeters, okay, that's what the airway looks like. And on the far left, that's sort of what that neutral position looks like. So what we like to call it is CPR while you sleep. Again, a dentist, living in the medical world. So that sort of leads me to my next segue. Chad, I think he has some pretty important insight on how we can sort of get this process started. Chad, please.
Yeah. So thanks, Dr. Paz. We AMI and Awaken Sleep both have some special offers for you guys tonight. When it comes to getting started with sleep, Dr. Paz's framework he showed you earlier, screening for sleep apnea, getting tested or your patients tested for sleep, all of those things, we got to have a curriculum to reference. There's all the boards, all the papers that have been published out there that explain we need to be involved, that as a dentist, you should be screening, treating, and testing your patients. And so at the end, we have an offer for everyone here. If you want to get some access to some really great CEs, that's a lot different than what you're seeing a lot around today with all the digital content that's around. We've got a special offer for you there. And Airway Management has actually provided a free MyTap for everyone who's in attendance tonight. We'll go over some of the details of that promotion a little while later as well. So thanks, Dr. Paz. I did have a question for you actually before we jump back in.
Yes,
And
please.
you had mentioned testing for OSA. And so someone had asked in the chat, what home sleep studies are you familiar with or that you've seen and like in your protocol?
So I like positional. So I like ResMed Apnea Link because it does provide you the positional component. It does provide you with the belts that determines if there's any resistance in breathing, and also the nasal cannula because that determines if there's any oxygen. Because not every apneic event, there could be some central apneas. So there could be a positional component. Maybe the patient only has apneic events while they're on their back. Okay. So just because they have sleep apnea on their back doesn't necessarily mean that they have sleep apnea. Perhaps if you were to do a corrective measure as far as trying to keep them on their right side. Why the right side? Because that places less strain on the heart. So that is my preference, is the ResMed Apnea Link. But there are some
Awesome.
others out there. The WatchBat one, they use a little bit different technology where it's more of an analog, but that's also an effective measure.
Wow, I was actually aware that you used the ResMeds. The other really awesome thing about the ResMeds, besides the fact that they are incredibly durable, is the disposable costs on those units are very cost effective. I mean, you're looking at less than $15 to do a cannula and a belt swap out if you're, operating those things. We've been using ResMeds for years, so that's awesome. Cool. Sorry to interrupt. Keep on going.
Yeah, no problem. So, where do I start? So tomorrow's Wednesday, and you say, well, how do I do this? Start with tomorrow morning during your briefing, your huddle, your meeting, whatever you want to call it, you sit down and you implement a protocol. Okay. Chad's they Awaken to Sleep has a great course, but you just simply and formally can start with every staff member. You can do an Epworth sleep study. There's different ways of doing it. Okay. And you develop, in my opinion, and you sort of grow a sleep coordinator. You need somebody that's going to be your go-to sleep person. That one person, perhaps their husband has severe sleep apnea. Perhaps they are like most patients that are not able to use a CPAP. That is a great individual to start with. Okay. Maybe you have your postmenopausal insurance coordinator. Okay. And I say postmenopausal because once menopause kicks in, we lose the estrogen tonic effect to the skeletal muscle. So the playing field is sort of leveled, okay, between men and women once menopause hits. So where am I going with this? Maybe that's an individual that has been kicked out of the bedroom. Maybe they are no longer welcome because a husband said, I don't want you. We have a bedroom divorce. That is a great individual that you can sort of start off with. Okay. So as your new patient comes in, look at the medical history. Okay. So some of the hypertension, some of the diabetes, some of the thyroid disorders, some of those, refractory or resistant hypertension patients, when they tell you, you know what, doc, I'm on 2 or 3 different blood pressure medications. That's really important. Okay. That's really important because one acronym that I like to share is called HEARTS. Okay. HEARTS is a really important acronym. Those are some of the comorbidities that are associated with that undiagnosed sleep apnea. Okay. So, heart disease, elevated blood pressure, atrial fibrillation, resistant or refractory hypertension, type 2 diabetes, stroke. Okay, hearts. That is a really powerful acronym. During the hygiene check, you can have your hygienist go over that information, and as you're updating every 6 months or every year their medical history. Just a general, hey, how you doing? Doc, I kind of had a long weekend, or I'm still trying to recover. When patients say that they're still trying to recover, number one, either they party a little bit too hard, which might be the case. It is COVID. People are getting a little antsy. Or two, it just might be that they're not sleeping well. Okay. That they go to bed, they're in bed for 10 hours, and they're just not getting that sleep. Okay. So, in my opinion, you can start with your team, but branch it off to those new patients and those pre-existing patients. Lastly, I hate to burst people's bubble, but when you do a block, okay, when you're about to do a crown prep on number 30 and you do a block, you walk out of the room, you go do a hygiene check, you check your Instagram, what have you, and you come back, and oftentimes we're flattered that the patient is sound asleep and they're snoring. They feel so relaxed in my chair. I'm great. You know what? That patient probably is so sleep deprived, they fall asleep on a dime. Guess what? They can also fall asleep behind the wheel. So it's important for us to know. Okay. It's important for us to be able to identify. And if you're in those states, it's important for you to screen and get those patients a sleep study. Okay. Oh, sorry, slide. Okay, opioids is a huge situation here in the United States. We have about 92 million users. I say that because we have a lot of chronic pain management. Okay, a lot of chronic pain management is going on in this country. And we know there's a huge correlation with patients that use opioids and obstructive sleep apnea. Okay. This Epworth questionnaire on the lower left is highly effective. Once you start getting patients scoring 9, 10, 11, 12, they're at a pretty high risk of having obstructive sleep apnea. Okay. This is something that you can easily incorporate not only into your new patient exam, but this is something that you can easily incorporate into your hygiene or your periodic exams, the what is it, the D0120s, I think. So you can do that easily. If a patient says, no, you know what, I really don't have a snoring problem because I'm asleep. Well, this on the lower right is a free app, okay, and it's called Snore Lab. I think it gives you like an introductory, a teaser, like everything, right? So you can utilize the lower right apparatus, the Snore Lab, just to get an idea of how that patient is doing. Okay, because a lot of times they'll say, "I don't know, doctor, I'm asleep." Sounds like my wife might have a snoring problem. So it sort of makes a believer out of some of these patients, if you will.
Hey, Dr. Jeff,
Yes.
we actually have, we're not seeing a couple of your images on your slides. Little technical difficulty there. Oh, there it is. That
Is
one
it?
came back. Well, now you're there. Go and go to the next slide for us. All right, never mind. Images are back. Thank you very much.
Okay. Sorry about that. So you're at the chair side, you're having your hygienist. Sometimes the hygienist is a really good driver of sleep. Okay. So some of the obvious things, right? Obesity, also the size of the jaws, that splint that we really want to make. And I'm sure that 99.9% of individuals that are viewing and are participating are fantastic practitioners. I'm certain of that. So that mandibular tori, that scalloped appearance of the tongue, if you can kind of see the lateral border, that sort of triggers a splint, right? A TMD splint, occlusal guard, night guard, whatever you want to call it. But all I'm asking is for you to kind of view sleep as the new vital sign. So you've already taken the blood pressure. You probably are taking temperature because of COVID, right? You may even be checking the pulse ox if you're sedating these patients. So kind of adding the sleep, the Epworth or the stop bank, that's sort of incorporating another element into your practice. Think of how that will set you apart, especially during these times. Okay, so that's all I'm asking is as you're starting to look down these patients' mouths, you're doing a hygiene check, you're a hygienist, you're placing an implant, the patient's sedated, they're gagging, they're choking, every like 15 seconds. I just ask for you to consider these things, the list on the left-hand side, okay? The scalloped tongue is really important. The tongue isn't only the size, right? Or the length. So there's three positions of the tongue. If you go below the occlusal plane, that's kind of the more favorable position. And it's simple. You can just have the patient relax, okay, open their mouth a little bit, and you have them breathe through their nose. If they're able to relax and place that tongue below the occlusal plane, that's a pretty favorable position. The second favorable position, not as favorable, we're kind of like going toward the medium and then to the high risk, is if they're right at the occlusal plane. The least favorable position would be if you ask the patient to say ah while they're breathing through their nose, okay, and all of a sudden that tongue goes all the way up, and for example you would score them a 3 or even a 4 as a Melampati. Okay, so these are very challenging cases because they're not able to keep their tongue down, so more than likely they're going to have some obstructive events. The usual suspects, the large tonsils, the long, sort of the elongated palate, okay, and the uvula. Does the uvula look, is it red? Does it look what I consider a boxing pear? Okay, if it looks red, it looks like a boxing pear, it's elongated. Well, guess what? More than likely, that patient is going to have sleep apnea, right? Because when we change that intrathoracic pressure, that's kind of what goes to the issue of GERD, right? We have a sphincter from our stomach to our esophagus that doesn't close because of the you kind of change, you go from -5 to -15 atmospheres. So you change that intrathoracic pressure. Well, guess what? The patient is not able to close that sphincter, so those contents come up. And some patients will say, you know what? I don't taste something bitter. It doesn't taste acidic. That's okay. Sometimes even the mist, what we consider the acidic mist from the stomach, will cause erosion. And we've all seen that erosion. So that's kind of something that we want to look for. Obviously, the snoring, the witness apneic events. Now we start getting into somewhat of a topic that, in my opinion, I hold very close to my heart because I'm in an area that has a lot of, I don't know, I would call them the fit soccer moms, the 35 to 45-year-old females. And a lot of them, I just noticed they can't sleep well. A lot of them have anxiety. A lot of them get placed on medication because they say, you know what, you're just too strung out. You have too much going on. You really need to take care of yourself. Well, sometimes it's difficult, especially with children, right? And that's kind of one of the things that I like to talk about is called female fatigue and what sleep got to do with it. Because unfortunately, our female patients will say that they have morning headaches or they just don't feel well. So that's kind of an interesting segue for your
Dr. Paz, we lost you for a second there. You're a little frozen.
the taps.
Oh,
They have
Dr. Paz.
yes.
Sorry, you froze for a good 30 seconds there. If you want to go back, show that last image. Um, and you just finished up with female fatigue, but I do have a couple questions for you. Actually,
Okay.
you can go back to the next slide if that's where you were, if you want to. We got two questions relevant to screening and kind of collaboration here.
Yes,
Uh,
please.
the first one from Ashley Walker: what would be a good introduction for sleep apnea to an orthodontic patient who is not being referred already for sleep apnea? I am from an orthodontic practice, not a GP.
It's fantastic you say that because in our practice, so we have an orthodontist that sort of looks at children's airways, and we also have a sleep ENT. So we form what we think is sort of the trifecta. So my conversation would be, hey, why not do a sleep test? If you look at some of these things, if you look at the size of the tongue, if you look at the mandible, right? I jokingly tell people, I'll look at their, when I'm evaluating the patient, I'll look at the tongue and I'll say, you may have a pretty normal sized tongue. You have a smaller lower jaw. You have a real estate problem. Okay. If you have some of those comorbidities, or maybe you have snoring, or maybe they don't know if they have any snoring issues, then they can always utilize the snore lab and see what that would do if they're resistant to do a home sleep test. Okay, so that would be my recommendation for an orthodontic patient.
Awesome. Um, and then another question. During my sleep training, I have been taught the opposite of desirable tongue position. When the tongue sits low on the floor of the mouth, it is more likely to cause obstruction when the patient is sleeping. This is also the mentality of myofunctional therapists. Do you ever collaborate with myofunctional therapists?
Rarely.
One moment, experiencing some technical difficulties.
With them.
Oh, Dr. Paz, you said rarely and then you cut out. So could you say that again for us?
Sorry. Is it my headphones, or let me see?
It would look like an internet connection. You froze. So
Okay, I'm sorry about that. So,
that's okay.
rarely do I unfortunately have not established a really good relationship with a myofunctional therapist. If you know of any in the San Antonio area, I certainly would love to learn and collaborate with them, but unfortunately not at this time.
Awesome. One last question for you. How many signs and symptoms do you see before you consider a patient at risk for an airway concern? At what point do you say we need to do a test, or snore lab if they're resistant to that?
Well, it kind of depends if we're going medical or we're going dental. If we're going medical and the patient says that there is a witnessed apneic event where they stop breathing, that's a trigger for me. Everything else, if they're not sure, they're hypertensive, their family member, they have a history, okay, of obstructive sleep apnea, then that would be a trigger for me. If I go into the mouth, right, if they're mouth breathers, if they look, if patency is an issue in their nose, right? So if you look at the internal and external valves, and sometimes they have an issue maintaining nasal patency, then that's also a red flag for me. But I like to look at the tongue and the tongue to me tells a lot. And I like to look at the uvula as well.
Awesome. And do you have a company that you know that does home sleep test shipping? You had mentioned for the orthodontic practice earlier, shipping a test to them or getting them a test.
Um, yes, I mean we work with several. So Snap works pretty well. Blackstone works pretty well. Virtuox, sorry, works pretty well. There's a group out of Seattle, Dedicated Sleep, that works pretty well. So
Cool.
there's a couple of drop home sleep test companies in the country.
Awesome. Alrighty. That's all the question we had for that section. Thank you.
Okay, thank you. I'm sorry about the poor connectivity. I wish I could say it was Friday, but it's only Tuesday. So I'm sorry, Chad. What did we need to repeat this slide?
Nope, you're good to go. Keep going.
Okay. Okay. So this is sort of the armamentarium. And full disclosure, Dr. Keith Thornton is a remarkable clinician. I don't know of many physicians, dentists that are sort of at that individual's level. He has a remarkable, he just has a different mind. I don't know how to explain it, but these are phenomenal products. We use taps in our practice. We do use some other appliances, but honestly, our go-to, I like to kind of call the tap our Toyota Land Cruiser, because you can kind of do almost anything with them. So, as we're kind of going through this series, how do we decide who gets what? Okay. On the lower left side, again, as I mentioned, San Antonio, huge military city. So imagine you're on a 17-hour flight, okay, and they're trying to get pre-jump rest. So imagine if 5 of these servicemen or women have sleep disordered breathing. What's that going to do for this entire unit? Okay, just think about that. And I didn't really put these things into perspective until I realized, for example, that on the lower right, I was one of the faculty for the Army short course, September this past year. These are individuals that need to be ready. They need to be ready. They need to protect us from harm, right? But these individuals, these servicemen and women, they too suffer from sleep apnea. Okay, so the sort of the center, that's the Department of Defense, the sleep disorder breathing guidelines. The page is kind of important, is page 26. On the upper right side, what we noticed was that there was a study from 2005 to 2019, and it said that there was an increase of obstructive sleep apnea and insomnia, okay, from 11 to 333, and from 6 to 272, and that was per 10,000 servicemen and women. So the point is, again, it's not just a older, heavy individual's disorder. Even the fit can have this issue. So one of the interesting things that I found was our female patients, and sorry, it's one of the cosmetic companies. They sort of qualified poor sleep and bad skin. And I'm not a dermatologist, but I'm just kind of getting into the conversation that we have, a makeup cosmetic company sort of leading this sleep. And as dentists, being in the mouth, we should also be looking at some of these conditions as well. That's my whole point. Okay. So this was a patient that I had 2 weeks ago. So what do I mean by the non-believers? Because sometimes our patients are very resistant. They say, nope, I sleep fine. I don't have any issues and I don't care. I'm going to die of something anyway. Well, this particular patient, he's a 45-year-old male. He has hypertension, type 2 diabetes, and he had an Epworth sleepiness of 19. His BMI was 32. Okay.
Hey, Dr.
It
Paz, we can't see the images on the screen. Can you hit the next button? Oh, go back one. There we go. Thank you.
okay. Sorry about that. Is that can you see him now?
You're good to go. Thanks.
Okay. So 45-year-old patient, BMI of 32. His Epworth was 19, but he felt fine. Okay. This is his airway. So those are like kissing tonsils. I immediately took a picture. Our sleep ENT partner was not here that day. I sent him the picture and he goes, Jeff, if there was ever a sleep emergency, you just found it. Okay. So that individual would have been a prime candidate for a MyTap, for example. Why? Because he's not doing well and he's not getting the air, the oxygen that he needs. We ended up sending him to surgery, and he should be, surgery takes a while to recover. So we'll be seeing him back in a October time period, and we'll initiate therapy with the MyTap. Some of the other non-believers. Okay. Again, I mentioned my soccer mom demographic. Awaken to Sleep, they're out of Southern California. So sometimes you'll have patients come in and they'll say, you know what, I'm going to have a girls trip. We're going to Napa, or we're going to the San Ynez Valley just outside of Santa Barbara. And I snore. And I know I snore and I don't want to snore. So what can you do? You can get them into a MyTap, and you can have them download the Snore Lab and kind of get an idea of what that MyTap does for the snoring. Okay, is the video okay? Everybody can see the screen, no problems?
Yeah, you're good to go. I do have one question before you hit the video, though. This is actually asked as we started here. How do you address vertical dimension in your appliance design?
Ha! So that's a really good question. And all right, if we go back here, for example, the MyTap and the custom tap, well, the taps in general, here they have a little shim, okay, for the MyTap, and here is a plate. You can actually raise that plate. So what I like to do, I look at the tongue. If the tongue looks like an average size tongue, I'll go between a 6 or a 9. If a tongue looks like it is humongous, I'll go between a 9 or a 12. And that's just clinical experience. And that's just with what I have an understanding. Obviously, we know if a patient's missing teeth, they're going to have a pretty large tongue, right? So from a buccolingual standpoint, so I would probably tend to go more along the 9 or the 12. But that is a really good question, because ultimately we know the hallmark of oral appliance therapy is it brings the lower jaw forward, the tongue is tethered to the lower jaw, right? And it stabilizes the jaw. But at the same time, sometimes we do need to open up that bite. So that is a very good question. Thank you for asking. Okay. So this is a MyTap fitting video. So we'll go through the video and we'll sort of point out common, some common troubleshooting.
Actually, Dr. Paz, could you pause that real quick and hit share screen again and share computer audio?
Wait,
I don't
I'm
think
sorry,
the
what's
audio.
that?
Hit share screen again and make sure that share computer audio is selected.
Let me see. Share screen. I'm sorry. I'm having
That's
all
okay.
these kind of issues with this.
Hit new share on the green arrow, and
Mhm.
then application, and then just make sure it says share computer audio. All right.
Is
Give
that
me 1 second here. I'm not seeing the option for you, so just give me 1 sec.
I could try the hyperlink. I don't know if instead of the embedded video, the hyperlink would.
All right. Okay. I think we should be good now.
This seaside Verbo is about to play host to an unforgettable vacation.
Sorry for the technical issues, everyone.
Sorry about that.
All right. This is so far the most difficult screen share I've experienced with Zoom lately. So thanks for updating yourself, Zoom. 1 moment and we're good to go. All right, here's the video, everyone.
App is a precision fit treatment solution for snoring and sleep apnea that is both patient-friendly and affordable. The design is based on the most effective oral appliance on the market, the TAP. MyTap advances and stabilizes the jaw so that the soft tissues of the throat and tongue do not collapse into the airway, preventing snoring and sleep apnea. The hardware on the front of the mouthpiece allows you to be in control of the treatment position by adjusting how far forward the lower jaw is advanced. This range of adjustability is not available in any other oral device and helps your treatment be more successful. The trays are made from an innovative plastic that softens when heated and molds to the teeth. The material is unique because when reheated, it returns to the original shape, which means that you may repeat the fitting process as many times as needed in order to achieve the perfect fit. Features of the MyTap include low cost, comfortable fit, freedom of movement, sleek and streamlined design, wide range of adjustability to fit any need, adjustable while in the mouth, remotable trays. Do not use the MyTap if any of the following apply. You are under active dental treatment. You have removable dentures or bridges. You have temporary crowns. You have loose teeth, loose crowns, or loose fillings. You have braces. You have less than 8 natural, healthy teeth in each arch. You have not seen a dentist within the last 12 months. Fitting the upper tray. Remove the MyTap from the case. Disengage the upper and lower trays by unscrewing the adjustment dial and separating the trays. Set aside the adjustment dial in the lower tray. Place the upper tray over your upper teeth. Bite down gently to check that your teeth fit within the flat surface of the tray. If not, you will need to narrow or widen the tray later in the fitting process. Pour boiling water into a bowl. Submerge the upper tray in the water for 1 minute. Remove the tray with a pair of tongs. Shake off the excess water and wait for 20 seconds, allowing the tray to cool slightly. Place the tray over your upper teeth. Be sure that the adjustment post is directly aligned under the nose, as this will center the tray. This can be accomplished by looking in a mirror. Bite down gently and close your lips around the tray for 1 minute. Let the natural pressure of your lips mold the tray to your teeth. Refrain from using your fingers to press the tray over your teeth. After 1 minute, use your fingers to smooth out any excess material to create a flat surface over the molars. Allow the tray to cool on the teeth for an additional 3 minutes. To remove the upper tray, place your fingers on the top edge of the tray on both sides along the molars and pull downwards. The tray may be slightly loose, but it will continue to tighten as it cools. Run the tray under cool water or put it in a bowl of cool water to speed the cooling process. Place the upper tray back in the mouth and check the fit by pulling on it and wiggling it from side to side. Set the upper tray aside to completely cool while you fit the lower tray. Fitting the lower tray. Fitting the lower tray is slightly different than fitting the upper tray. and requires more steps. Place the lower tray over your lower teeth. Bite down gently to check that your teeth fit within the flat surface of the tray. If not, you will need to narrow or widen the tray later in the fitting process. Pour boiling water into a bowl. Submerge the lower tray in the water for 1 minute. Remove the tray with a pair of tongs. Shake off the excess water and wait for 20 seconds, allowing the tray to cool slightly. Don't shake too hard because it could cause the hardware to dislodge. Place the tray over your lower teeth. Be sure that the adjustment post is directly aligned under the nose, as this will center the tray. This can be accomplished by looking in a mirror. Bite down gently and close your lips around the tray for 1 minute. Press your fingers below your lower lip and against the front part of the tray along the gum line and lower teeth. Use your tongue to press against the inner side walls of the tray. After 1 minute, use your fingers to smooth out any excess material to create a flat surface over the molars. Allow the tray to cool on the teeth for an additional 3 minutes. To remove the lower tray, place your fingers on the bottom edge of the tray on both sides along the molars and push upward. The tray may be slightly loose, but it will continue to tighten as it cools. Run the tray under cool water or place it in a bowl of cool water to speed the cooling process. Place the lower tray back in the mouth and check the fit by pulling on it and wiggling it from side to side. Reassemble the MyTap trays. Daily use of the MyTap. Before daily use, inspect your MyTap. If you notice any defects, do not use it and contact your prescriber. Place both trays in the mouth. Make sure that the lower tray is not dialed too far forward, because you may not be able to bite into the appliance. Gently relax your jaw once the MyTap is in your mouth. To pull your lower jaw forward, turn the adjustment dial counterclockwise towards your left ear. On the first night, start with the MyTap in a neutral, comfortable position, or in a position.
All right, Dr. Paz, go ahead and take it away. Give you back control of the screen. That is how to fit a MyTap. So we explained everything in under 5 minutes. Well, the video did. And I think this is available on YouTube, if I'm not mistaken.
Yes. Let me see where.
While we're doing tech stuff, we do have a question. Can you do a backflip while on a trampoline?
You know, that's not good for the hair, so I tend not to do those things. That's a good one. Let me see. What do I? Sorry, here, Chad. What do I?
Go and hit share screen and just hit the screen that you're looking to share and hit resume PowerPoint. Alrighty, there you go.
Okay. So some of the, some of the things to kind of avoid, obviously it's slightly technique sensitive, like anything. I mean, I kind of like to tell patients, it's like when you started taking x-rays in dental school, right? You wanted to coach the patient because you're trying to put something in their mouth. The tongue can be a little bit of a problem, so you want to sort of coach the patient to breathe through their nose. One thing you don't want to do, you don't want to overheat the trays, because then they become very, very wispy, and it can be hard to sort of shape if you have an overactive tongue. Okay, the alignment is important. As I mentioned, you kind of want to put the protruding rod. You want to line it up with the nose. Because if you can have alignment issues, if you're off, then obviously as you're protruding your patient to maintain a patent airway, it is possible for you to cause some jaw joint issues. The rolled tray borders, sometimes you want to make sure that the trays are long enough from from an incisal gingival standpoint. So sometimes you do have to add a little bit of thermocryl to make the tray a little bit longer. But the best way to do that is you insert inside the patient's mouth, and you just want to make sure that it's not rocking. Okay. But eventually you do want to coach the patient as far as like puckering. I don't know if any of you remember like the green stick compound of like border molding for partial dentures or complete dentures. That's sort of not as technique sensitive as that, but that's sort of the idea when you want to have that patient pucker so they can kind of engage the muscles. So, you know, how do you know when to stop? Subjectively, you know, you would ask the patient, how are they doing with their sleep? How are they doing with their snoring? How do they feel? Do they feel more or less tired? These are all really good ways of establishing what I call the subjective sleep spot. Okay. On the right-hand side is something called the night owl. I really like the night owl. You can do from 3, 4, 5, 6, 7 nights. So you can sort of titrate various positions. Okay. So this will give you an idea if this patient is responding to care or not. Okay. And that might be like a separate lecture, but on the right-hand side is a night owl, and that is a really nifty gadget. Okay. Because from that point, maybe you can get the patient into a custom dream tap, for example, or some patients may require a hybrid therapy. Okay, and that's where you literally are merging the oral appliance to a chair side nose pillows, for example. In this case, these are what we call the tap pap system. I really like to thank everybody. I apologize for the technical difficulty. This is a patient that we treated, and it really kind of holds a special place in my heart because I'm sure you've heard, and I'm sure physicians and maybe other sleep dentists or dentists call the oral appliance a mouthpiece. So this individual has been using a custom face mask that we fabricated for over 10 years. Now, this is a post-polio patient, okay? He only has function of his left hand, okay? So this individual, without being able to literally bite that mask into place, he would have nothing. He's on a respirator 24/7. So I always kind of take not offense, but this case always lingers in the back of my mind when, for example, we do lunch and learns, we do roundtable discussions with physicians, and they sort of say, oh yeah, that mouthpiece seems to work for some patients. And I always carry this case on my phone and I say, what would you do in this case? Okay, so I encourage you, if you want to just be a sleep ambassador and refer patients out, identify and refer, that's great. I think Chad and Awaken to Sleep, they have a fantastic course. I would encourage you to attend that course and not just be a sleep ambassador, but actually really help your patients, you know, because you could save their marriage or save their lives. Thank you so much for your attention.
Thanks. And Dr. Paz, if you want to go over during this time, we want to offer a time to do some question and answers, and you can just go over some of the offers from the sponsors today. So the first one, we mentioned earlier that we are discounting our course for all the attendees today. So if you are looking to get started in sleep, you want to learn how to screen those patients, you want to learn about testing protocols and the considerations that need to be considered in testing and treating patients. If you want to learn about appliances, all the different appliances that are available on the market out there, then this is a course for you. This isn't just some course where you come in and listen to someone talk, but you've got to have your camera on, you got to bring your team. I know Dr. Paz and I were talking earlier about the fact that teams are critical to the success of a sleep program.
Yes.
And we are discounting this so that 1 doctor and 4 team can come for a total of $400, $397. That's 5 people who get 14 CEs each, 70 CEs, $400. I don't know of another deal that you can get that many CEs for that. It's 2 days, and we see that practices are doing 3 to 5 appliances a month after these courses. So if you want to get involved in sleep, you want to learn where to start, this is where you need to go. You can go to awakentosleep.com to /events to see our next course, August 20th and 21st, and get that discount there. Additionally, Airway Management, and Dr. Paz, if you go to the next slide, is offering a free MyTap to all the attendees here today. Now, here's the catch though. You need to redeem this voucher within 10 days. That means that by next Thursday, I believe, or Friday, by next Thursday or Friday, you need to send this into them to get your free MyTap so you can try out the first 5 minutes of that video, see about some of those complications that Dr. Paz mentioned earlier, and really start to consider using this temporary appliance as it relates to your sleep treatment. There's a couple cases where this can work really well, and it could be interim while they're affected by that Philips recall. It could be they want to try it out before they commit to the full financial treatment plan, but this is a great way to test that out. We didn't have a slide for it, but our next webinar, which will be in the email, is going to be all about how to build physician relationships in light of the Philips recall. So stay tuned for that. And remember, this document, the MyTap voucher, the CE link, as well as the opportunity to get registered for those courses, all that's going to be emailed to everyone here within the next 45 minutes or so. If you don't have it in your inbox by tomorrow morning, reach out to us at info@awakentosleep.com. We'll make sure to get that into your inbox so you can use this voucher, get onto our course, and start treating sleep as soon as possible. With that, do we have any more questions? All right, I have one here. Dr. Paz, what do you charge for your temporary appliances?
So for the MyTap, for example, we charge $500, and that's something that we've certainly seen an uptick with 4 million Philips Respironics recalls, and that includes a consult, and that includes a follow-up appointment as well.
Awesome. All right, and what is the most challenging, or who is the most challenging patient to accept for treatment?
I think the sort of the younger female patient is our biggest challenge, but at the same time, they're really aggressive once they acknowledge that they do have possibly obstructive sleep apnea. As I mentioned, going on a wine trip, on a girls' trip, and they're sort of the last person that gets selected to sleep with. That usually gets them motivated, but they can be challenging, yes.
So are you saying that if there's a young female patient who isn't convinced they need a test or an appliance, that you should send them to a winery with their friends here in California, and it probably gets some more case acceptance there?
That's right. You know, we're promoting California tourism at the same time.
That's right. Yeah. You got another question here. How would you recommend handling patients affected by the CPAP recall?
So unfortunately, not a lot is going on. Okay, so this is kind of what I was alluding to earlier. Why not us? Why not us that are in a position to be able to do something? So what we're doing, we're taking a lot of calls from PAP users that obviously are not able to use. So we come in, we have the patient come in, and we have them try a MyTap. A lot of them say, you know what, I like this. I didn't even know this was an option. I want to move forward with the custom appliance. So it really has been a good situation for us. Now, as far as the sleep physician goes, we have reached out to sleep physicians in our area, and we say, we're a resource. We're willing to work with you as well. And it's worked out well. And we want to, we're not a true specialty, but as a service, we really want to make sure we posture ourselves in a positive light. And this is a time to do it. It really is. As a good friend of mine, Matthew, says from SomnoMed, he says, you know, you follow the North Star, and that is what is best for your patient. So yeah, that's what we're doing in practice.
Now we got a couple more questions. Mike asked, how does the MyTap hold against heavy bruxers?
So, it's really only meant for about 3 to 6 weeks. Because again, what we're wanting to do is determine if the patient is going to respond to therapy. So that just kind of goes back to how heavy is heavy. It is a
Got
pretty
it.
resilient product, but at the same time, I could show you, 30 different cases of patients just chomping down, compromising the structural integrity of oral appliances that are custom made. So it just really depends how heavy is heavy.
Yeah. Great question. Another question: are temporary appliances able to be used on children?
Ooh, that is that is a really good question. And I have an 8-year-old daughter and a 5-year-old son. And I don't know that answer. And I probably don't know that answer because I don't treat any children in my practice. I'm just being completely honest. I feel that children are like sharks with me jumping in the water with the cut leg. They just smell the fear and they come after me. So I honestly do not know. But I have some really good colleagues, either in Dallas, that do treat children. So I'm sorry,
Yeah,
I'm not able to answer that question.
that's okay. I do know very vaguely, very 10,000 foot view. Typically, it's not recommended to put patients into any kind of appliance that would restrict growth. So the appliance is
Correct.
only designed for 3 to 6 weeks, as Dr. Paz said. So you wouldn't want to put a patient, probably a pediatric patient, into a temporary appliance. We'd likely refer them to a specialist, maybe orthodontics to expand the palate, all that jazz. So yeah, great question. Another question, and I'll probably take this. How could I get a night owl test for myself to try it out? Awaken to Sleep would be happy to ship you one of these deals. I've got one right here on my desk. If you can just go to our websites. If you want information on how to get a discount for this, email us, info@awaken-to-sleep. We're happy to give you an extra discount, ship you a test right to your door, so you can try one of those out. All right. If there are no more questions, then I just want to recap the closing comments and we'll dismiss for the night. Our team should be posting the CE link in the chat. If you don't see it in the chat, it'll be in your email momentarily. If you want to get registered for our 2-day course with that $200 discount, so you're only paying $400 for 70 CEs for you and your team, then please make sure to register by next Friday. Seating is limited. I want to say we only have 5 spots left anyways. So make sure you grab your spot for this month if you want to attend and get those CEs. And remember, you have 10 days, the same timeline, next Friday. Redeem this free MyTap voucher. Try out this temporary appliance. It's not designed for permanent therapy, but if you have patients that are affected by the Philips recall, if you have patients that want to try it out before we move them to a permanent appliance, the MyTap could be a great solution for you in your practice. So, Dr. Paz, is there anything else? Oh, do you give an activation code for the Night Owl?
Yes.
When you order, yeah.
Oh, sorry.
No, yeah, great. For ours, we activate it before we send it over to a patient, but we're typically paid for that. And for Robert, if you want to try one out, you let us know. So, Dr. Paz, is there anything else you wanted to wrap up and say?
No, I just, I'm humbled and thank you. Thank you for inviting me and thank you for everybody participating. And it's a fantastic organization to be a part of. Thank you. Awaken to Sleep.
Awesome. And just so you know, Ron Bishop, thank you for complimenting Dr. Paz and I believe Dr. Thornton as well. And Ashley Walker, thank you again for your participation. Your compliments are always appreciated. Thank you guys for attending tonight. Your CE link will be sent to you shortly. It's in the chat right there. And we look forward to seeing you next time.
Thank you.